definitely have a quorum. Okay, so this is a joint meeting of EMCC and the Medical Advisory Committee, and to ensure we coordinate the meeting well, we're just want to give a couple of ground rules so you know what to expect. First, MAC is a subcommittee of EMCC, so Tina Nieto, as chair of the EMCC, will call the meeting to order and do the general meeting coordination. When a action is needed to be taken, EMCC will do their action first, and then it will turn over to Dr. Burley as chair of MAC to run that action, and then we'll come back to the chair of EMCC to continue moving the meeting forward. Basically, that's it. If there's an introduction to an agenda item, it will be done by Chief Nieto as chair of EMCC. That's basically it, just so you know how the meeting will coordinate, and staff will do everything we can to help make sure that the meeting runs smoothly. And with that, Tina, I think we're ready for.
All right, calling the special meeting, joint meeting between EMCC and the MAC to order. And with that, can we get a roll call, please?
Yes, roll call. Will Hiller.
Here.
Tina Nieto.
Here.
Sam Klemick.
Here.
Jim Lamborg. Harry Robbins.
Here.
Luz Garcia. Paul Wood. Nicholas Greenson.
Here.
Greta Steinbrunner. Carla Spencer. John Anthony. All right, moving to the alternates. Cheryl Getz. Ben Harvey. Joe Cafaro.
Here.
Thank you. Keith Boyd, no, sorry, Bandy Smith. All right, we do have a quorum. Ex officio members, Teresa Rios.
Steve, can you add my name?
I'm sorry.
Jody.
Oh, Jody.
I'm here.
Thank you. I'm sorry if I missed you. Ex officio members, Teresa Rios.
I saw her mouth move. She said here.
She's here. Yeah, Gary Millay. And Leanne Magoski.
Here.
Jim Langford is here now.
Jim Lamborg. Perfect. Thank you. All right.
And Noah Hawthorne as well.
Oh, wonderful. Thank you. So anybody, alternates that I didn't call who would like to announce?
Hey, this is
Steve, it's Roger. I'm on.
Roger, thank you.
Steve, not an alternate, just got on late. Jim Langborg is here.
Perfect. Thank you.
This is Derek Orchard representing Natividad.
All right. With that, then let's do MAC, and then any guests who are on neither of the committees can announce their presence if they wish.
Okay, for the MAC subcommittee, Dr. Kalinsky.
Here.
Dr. Hawthorne.
Here.
Dr. Orchard.
Here.
Dr. Greenson.
Here.
Susan Burnell is the alternate for Christy Soboleski.
I'm here. Stella will be sitting in pretty soon. She's just delayed.
Great, thank you. Tiffany Wallace. Cassie Caldera.
Here.
Carrie Campman.
Here.
Will Mealand. Ryan Alexander is the alternate for Scott Houchin. Ben Hitchcock.
Here.
And Tina Nieto.
Here.
Anyone from MAC as a primary and alternate that I may have missed? All right.
All right. At this point, guests, who are on neither EMCC or MAC. If you'd like to announce your presence, it is not required.
Morning, Mike Hesslinger with AMR.
Rachel Nealand, AMR CES.
Kelly Turpin,
Chris
AMR
Cosmo,
ET3 Program Director.
Mark Amber, I'm an emergency physician and ET3 program lead.
Alex Hosta, AMR Santa Cruz.
Mitch Catersecker, AMR.
Sandra Flores, AMR Monterey Communications.
Paul Wood, representing the city managers.
Oh, good. Thank you. Anyone else would like to announce their presence? Very good. Thank you.
Thank you for that. Moving on to the AB 361 to continue our COVID meetings. Steve, I guess we need a motion from somebody.
Yes,
You
I
have a
would
motion.
recommend that
You have a
the
mo-
motion, that the motion fits what is written on the staff report so that we meet the requirements for AB 361.
Go ahead, Harry.
Okay, I move that we find that due to the current surge in COVID and associated statistics, we find our AB 361 that is necessary to continue to meet by Zoom.
Can I get a second?
Second.
I'm sorry.
That
I
was
didn't catch
Jim. Yeah, that was Jim
Yep, thank
Langford.
you.
Jim.
All right, could I get a roll call, please?
All right, roll call for EMCC. Will Hiller,
Aye.
Tina Nieto,
Aye.
Sam Klemick,
Aye.
Jim Lineborg,
Aye.
Harry Robbins,
Aye.
Jody Schaefer,
Aye.
thank you. Luis Garcia, Paul Wood,
Aye.
Nick Greenson,
Aye.
Carla Spencer, Joe Cafaro,
Aye.
John Anthony, Randy Smith. All in favor.
Thank you for that. And also, Steve, Jeannie Alexander from Big Sur Fire is on. She texted in the chat box.
Okay.
And before I turn it over to Dr. Burley for the next item on the ET3 discussion, I just want to throw a shout out to Sam Clement. He has been named the fire chief in his city. And so Sam, big congratulations. And I don't know, is it fire chief now, not acting, or have you been sworn officially? So I'm going to turn it over to you, going out of order just a little bit.
Thank you, Tina. Appreciate it. Yes, it is official. It's been announced. It's just we haven't had any pomp and circumstance for it yet. So a pinning and a swearing to be determined at a later date. But thank you very much for the shout out. Thank you, everybody. Appreciate it.
All right, with that, Steve, can I turn it over to Dr. Burley now for the ET3 discussion? Or is
Let's
that
see.
whose discussion is that? Is that Max or EMCC's discussion?
We still need
No,
the MAC
it's-
AB 361 before we move on.
Yeah, Max got their AB
Okay.
361.
All right, I will turn it over to Dr. Burley then. Dr. Burley?
Thank you, Tina. Congratulations, Sam. We'll go ahead and move forward with the, sorry, one second. There we go. We'll go ahead and move forward with the AB 361 agenda item. So this is in support of continuing meetings remotely under California AB 361. We'll need a motion to continue that.
This is Tina Nieto. I move that pursuant to AB 361 that we continue to meet remotely.
Thank you, Tina. Do we have a second?
Second.
Okay, Dr. Orchard, thank you. So we have a motion and a second, and we can go ahead and take a roll call vote on the agenda item.
All right, Dr. Kalinsky,
Aye.
Dr. Hawthorne,
Aye.
Dr. Orchard,
Aye.
Dr. Greenson,
Aye.
Christy Sobolewski,
Aye.
Tiffany Wallace, Cassie Caldera,
Jacob.
Aye.
Carrie Campman,
Aye.
Will Mealand, Ryan Alexander for Scott Houchin, Ben Hitchcock,
Aye.
and Tina Nieto.
Aye.
All right.
Okay, sounds like the motion carries. So with that, I will turn it back over to Chief Nieto.
Thank you, Dr. Burley. Moving on to number 3 on ET3 discussion, presentation by AMR.
Everybody, I just wanted to say thank you so much for taking time this morning to participate in the special meeting. I'm going to introduce Kelly Turpin, who is our Director of ET3, and she was going to provide just a brief presentation and kind of a slight overview, and then help answer some questions that came up during our last meeting. So thank you, Kelly, and I'll turn it over to you.
Thank you, Mike, and hello, everybody. Nice to meet you. I've met a few of you, but certainly not everybody as a large group. Yeah, thanks for the opportunity to come back together. What we wanted to do today is, I understand there's quite a few follow-up questions from the last presentation. So I put a deck together, which I'll pull up. It really is just kind of talking points to make sure we cover all the topics that I believe you wanted us to circle back on. So I will start just very, very briefly outlining, again, just making sure we're all starting from the same starting point on, the purpose of the program and our goals. And I'm going to turn over to Dr. Mark Gamber, who's here from the Envision Telehealth Physicians to speak to, I think, some of the questions, concerns, follow-up items from the last meeting. Then we'll turn over to Mitchell Cater-Syker. He's out of our Syracuse operations and can speak to, he's been live on the program for about a year now and can speak to their experience having used this for quite a while and share some data and results that they've had already. And then finally, we have Ben Hitchcock, who can speak in depth to the CQI and the local operational quality assurance program. And then certainly, if there's still any additional questions or topics you want us to dive into, we will. But if that all sounds good, I will pop up my screen and just share, again, very much just high-level talking points to make sure that we covered off everything that was of interest to each of you. And I know that you started the last meeting again talking about exactly what this program is and why we're doing it. And I'm not going to duplicate that information, but just in case there's anybody new on this meeting who missed the last one, I think, the main thing I just wanted to get across on the program, and certainly we can talk in more depth about it as well, but I just don't want to duplicate the information that you already have. But with this being the CMS program, that came out with the very specific goal of providing flexibility to ambulances to treat the low acuity patients following a 911 call. What we're discussing today is being able to offer telehealth on the scene of a 911 call, again, for very low acuity patients. I'll talk about our clinical criteria briefly in one moment. But the main reason we're doing this, and this is what I think is the most important part, and I go over this in training with all of the operations before we ever go live, is that we're doing this for the community and we're doing this for the patients. And we do survey 100% of patients that go through the program, and the feedback is always overwhelmingly positive. Patients are very grateful to be able to have options other than just an emergency department visit to treat them. So quickly, some of the benefits to patients are safer at home. Certainly in California and across the nation, we've experienced patients that will decline care just because they are nervous about going into a potentially crowded, busy emergency department. So with our ability to bring the ER physician to the patient in their home or on the scene in under 5 minutes, that, you know, can be a tool for patients who would have otherwise declined to receive any care. Certainly cuts down on the patient's ED wait times and eliminates also the need for them to find another way home, and you know, decreasing patient costs with, you know, the average telehealth visit really being a fraction of an ED visit cost. We're also doing this to encourage appropriate utilization of services within the community as well, just because generally busy, crowded emergency departments, specifically over the past couple of years with, you know, some have experienced nursing shortages, some have experienced long wait times. Being able to keep the low acuity well patients out of an emergency department just helps with appropriate utilization of your local healthcare system. And then, of course, you know, there's also benefits to EMS as far as increasing efficiency, being able to treat these low acuity patients quicker and more efficiently on scene, which in turn frees up the EMS system to be readily available for, you know, true emergencies and time sensitive high acuity cases. I could talk all day about the benefits, but that is just at a very high level. You know, I just wanted you to understand AMR's goals with this program. And again, the patients we're talking about here, I understand you've already seen the clinical criteria, but we're talking about very low acuity well patients, ones that, you know, are not appropriate for an emergency department, or ones that would have, you know, refused transport to the emergency department anyways. In order for a patient to even be eligible for telehealth, they must meet the very conservative clinical criteria, which is, again, I think you already know the criteria, but essentially, you know, vitals very close to a normal range. And it also must be a pre-approved primary impression, which, you know, again, we have limited down. We have the list of that if anybody wants the more in-depth details, but it was, you know, developed by a team of national and also California specific medical directors. So we put that criteria in place just to, again, ensure we're doing our best to only capture low acuity patients. So that's my very brief overview. Before I hand over to Dr. Gamber to speak in depth about our, you know, the telehealth program and the physician side of it, are there any questions on that? Fabulous. Well, I know Dr. Gambers, whom you're all very excited to speak with. So, you know, Dr. Gamber, I'll turn over to you.
Thanks, Kelly. It's great to meet everybody virtually. Thanks for having me on today. My name is Mark Gamber. I'm a emergency physician, board certified in emergency medicine and emergency medical services. And I lead a group of 10 board certified emergency physicians, all of us with an EMS background as well. I was pretty specific to recruit board certified EM docs that understand EMS. And we take call for the program 24/7, 365. So happy to take a call, whether it's 2 p.m. on Tuesday or 2 a.m. on Saturday. We're ready to go. We are specifically not on duty in the emergency department. We are specifically on call for ET3 only when we're doing this. Our current call volume is not overwhelming. We're covering the AMR sites nationwide and probably averaging in the range of 7 to 8 calls a day. So I say that so that you understand there's not a big queue of patients waiting for us. And we have a tiered system in the event that 2 calls drop at once, so that we have a backup physician that can take the call. And that's why we're able to consistently have a response time under 5 minutes, because we're not already in the ER and because we have a really quick backup system. For the year 2022, our average response time is just under 3 minutes. I serve as an EMS medical director for Plano and Frisco fire departments in the North Dallas, Texas area, as well as being a local AMR medical director. And so having worked as an EMS medical director for the last 15 years, I understand the medics want a quick response when they trust us to call us. And so we've staffed to make sure we provide that quick response. We try and be efficient and expeditious when we talk to patients. Our average telehealth visit time is in the 9 to 10 minute range. So really you're looking at an investment of under 15 minutes to get a board certified emergency physician on audio video talking to a patient and your crew. And it's a great conversation. And I think now wearing my EMS medical director hat, I think an ancillary benefit for all the medics involved is that they hear a board certified ER doc talking to the patient, and they're part of that conversation. And there's just some passive learning, I think, that goes along with listening to me have that conversation. I was very involved in the setup of the program since the outset in the protocol that you see there. We have weekly group meetings, albeit it's a virtual group, but we have weekly group meetings within our group. We have weekly meetings with Kelly Mitchell and Dr. Jared Troutman, another board certified emergency physician who's the program lead on the AMR side for this, where we go through cases. So that's every Friday we get together and look at cases. Brandon Wilson, our director of operations, is in 100% contact with patients. So we're really tied into this program on a daily and weekly basis, and we're incredibly transparent with it. If any EMS medical director wanted to be involved in QA, there's a lot of ways to do that. So you can refer any case you want to us, and we're happy to look at it if it generated from your area. And if you want to get together with our physician group, we're happy to involve you in that QA program too. We're humble and we realize this is a new program. It's really aimed at low acuity patients. So we're good at taking care of, low back pain, of a rash, of upper respiratory infections. We certainly have had some COVID conversations over the last couple of years, but you can see by the vital sign criteria, if a patient gets to me, it's safe for that conversation because their vitals are really pretty rock solid normal, with a O2 saturation at 94% or greater, not being, very tachycardic, certainly not hypotensive. These are patients that I would normally see in the ED and treat and release without testing. And that's the kind of patient population we're looking here. I know if I were a local EMS medical director, one of my concerns would be, is their program reach? Are these docs trying to see, patients that are too sick? And I really want to provide an emphatic no to that. That's one of the values of getting a board certified ER doc, is if that story migrates from what the medic was told to what I'm told, I'll pick up on that. I'll say, oh, it's really more than vomiting. It turns out you have abdominal pain too. We really should get you seen in the ER for that. So we're conservative. We want to be able to treat in place, but having all of us practiced collectively for many years in emergency departments, we know what needs to go get checked out in the ER, and we practice medicine that if they need testing, they need to go to the ER to get checked out. We are now incorporating translation services into this as well, so we can serve all populations. So like Kelly, I could go on for an hour about this, but I want to stay brief and be responsive to your questions too. I certainly am happy to highlight our QA program, our clinical pathways, to share the background of other physicians, anything at all I can do. I'm happy to talk about billing, money, anything you want. Happy to go through it. I will tell you, it's a lot of fun. It is, and I will say, we've seen over 1,000 patients now. I've been a part of this live since late last February, as we provide services across the US for AMR. And the overwhelming feeling I get is that we're doing the right thing, that there are low acuity patients out there that benefit from this service. What I think will keep it strong is the constant conversation we have, with national and then moving to local operations. So I see a hand up, happy to answer a question there.
Yeah, I was actually kind of curious about the finances because, you said 12 board certified emergency physicians, 7 to 8 calls a day. I mean, yeah. I can't make the math on that work because you're talking about probably $2 to $4 million to some physician salaries there. And I don't. Yeah, and
it's hard to make the math work. I'll be quite honest. We had people volunteer for this. They weren't voluntold. It's a pretty innovative group who, wanted to try something new. Obviously, the physician benefit from this is we're practicing from our home. So that's kind of nice. And it potentially the group of physicians, again, they're kind of innovators. And I think we see that as this grows, it offers some career flexibility over time. But there's a time investment in that because we certainly make a whole lot less than we do if we were working in the emergency department. So, I'll just give you kind of a broad idea. Envision's average collections on a Medicare patient is around $85 for this. Our typical billing code is a level 2 or 3 emergency medicine visit code. Our typical collection on a Medicaid patient is about $65. I'm thankful, and one of the reasons I feel ethically sound in leading this program is we'll literally take whoever you give us. There's no wallet biopsy. We're happy if the patient's unfunded, whatever. We see whoever is referred to us.
Wait a second. So, because the program, when it's spun up right now, it's been pitched as only for certain payers.
Right.
So definitely the way it's being launched in this community is very payer specific right now, which is one of the issues that I think some of the community members have.
Yeah, no, and so it's up to each community how they implement it. And we respect each community's choice in how they implement it. But from our physician perspective, we are, payer agnostic.
All right, so I'm still kind of confused. So relatively low reimbursement rate, 7 to 8 calls a day. I mean, are you guys getting a subsidy from somewhere or something, or how's that financially working?
No, yeah. So we honestly don't make a whole lot doing this. We have a base pay of $20 an hour that we give ourselves, and then I'm paid $37.50 per patient visit.
All right.
So I'm without being able to sync the names up. I'm going to guess you're a physician, and you're probably inferring that's a whole lot less than we make in the emergency department.
Well, it's something. I mean,
there's no
doesn't make sense to me.
here. It's the only way I think this is challenging to scale and grow, right? And there's going to be a part at the front end of this where it's not, it takes a while to grow something and do it right. And so we've made kind of the investment to put really good docs up front, and we're hoping it grows. We're hoping it grows to other payers. Some commercial payers pay and some don't. Some don't recognize this yet.
How was the company founded?
So Envision is a big emergency physician staffing company, and there's a couple nationwide emergency physician staffing companies. This is one of them. I was part of a large group in Dallas-Fort Worth that became part of Envision, and they've been very supportive. I do this because I think I like it and I think it's valuable. And they said, let's try a program and see how it goes. We've got a great partner with AMR. So we're trying to grow it and figure it out.
But I thought the telehealth company was owned by GMR. Is that not correct?
No, it's not. We're separate companies.
So GMR is not the parent company?
No.
All right.
Who is Envision's parent company?
Yeah.
Yeah. No. So it's private equity owned, and it's. I get it. I get the negative connotation with that. I understand that. At the end of the day, I'm like you. I'm a board certified ER doc that goes and sees patients every day. I'm an EMS medical director, and I'm proud of the program we lead. And who owns us hasn't really affected me.
All right. Well, so is the private equity company the same equity company that owns GMR and AMR and Rural Metro and a CalStar?
I believe so. Yeah.
All right.
It's not the level I fly at.
There's a question from Dr. Orchard.
Yeah, so say another financial question. A patient in the field, low acuity, initially gets dinged, gets evaluated, and they find that they're probably a little higher acuity, needs to go to the ER. Do they get double billed? Do they get billed for the tele visit plus the ER visit and transportation?
Great question. The answer is sometimes. It kind of depends on if we feel we're providing value to the conversation. So if I look at the patient or one of my colleagues looks at the patient and we're like, hey, that's not hand tingling, that's a stroke, they need to be transported. That's a brief conversation. And so we have the ability to do a courtesy visit on that. If I spend 20 minutes on a conversation with the patient and I've got the family and the assisted living staff and the patient and the medics, and we're all going back and forth about what should happen next, and I'm providing a lot of clinical insight into why I think they should, probably go, that maybe this is a little more serious, I feel like I am providing some value, and we would bill for that. And I think honestly, as a system, that actually provides some protection for the system that we do that. Technically, it's not double billing because it's a separate code as a telehealth code. But yes, we would bill for that if we feel like we're spending adequate time and providing value on the call.
I guess that was kind of the initial concern with the 911 call, right? They probably wanted a higher level of care. So I think those are probably few and far between cases, but I would be concerned if I was a patient or my family member called 911, they thought it was an emergency, and they get an additional bill on top of that. I don't know.
I understand.
And I will say from the operational perspective, while, nothing is 100% foolproof, or one of the things we do talk about quite a bit in training is for how the crew present this to the patient to see if, they are actually interested in receiving telehealth, because the last thing, that we want is to do a telehealth visit and then exactly that they say, no, well, actually, we just wanted to go to the ED anyway. So we have done a fair amount of scripting and follow-up training with crews to, again, identify these correct patients who truly want to stay out of the ED, to also, to minimize that and make sure we're getting the right patient population.
I have a quick question. I think it kind of tags on to that. And if I missed this in the conversation, I apologize. But for the patient that's there and they do opt to do the telehealth and it's an elderly patient, is this new form of care, is it recognized by Medicare and or insurance companies? And then does this become part of the AMR bill? Does this become a separate bill? What is the end result for the patient?
So this program was created by Medicare, and we're following through on a program created by Medicare here. Probably the ideal application is that it moves beyond Medicare to all patients, because it's complex implementation for EMS to sort out something just for a certain group of patients. But other payers are slower. Some states, Medicaid has jumped on board. For example, Texas, where I am, Medicaid recognizes it as well. Some commercial payers, but not all, are recognizing this as a valuable practice of medicine. I think that was part of your question. What was the other part?
I was just kind of wondering what the end result financially was going to be for the patient. Then the other part, I think, was from an AMR standpoint, is this an add-on to the AMR bill, or is this a separate bill? What does the patient see later?
Yeah, so from the AMR side, there's no changes in their patient bill. So essentially, I say the benefit to us, it's most certainly not a moneymaker, but what it does is essentially just allows us to bill for the ambulance transport, or ambulance arriving on scene, even if they don't go to the emergency department. So Basically it's just the exact same ambulance response billing that would have been done. Historically, they've had to transport to an emergency department, which is why we see, low acuity patients going to the emergency department, because it was the only form of reimbursement. So there's no additional bills as a result of telehealth or as a result of ET3. It just is essentially status quo, if you will.
I'll explain it one other way. So if I had a patient who had, we'll say, bronchitis, and I were to prescribe something for bronchitis, it's the EMS visit is budget neutral. We'll call it a BLS transport or BLS treatment in place, same charge. The physician is budget neutral, most like, unless more testing was done in the ER by the physician, which would raise the coding of the patient. But essentially, you can think of the physician bill as probably budget neutral. Where the patient saves is that they don't have a facility fee, which is often substantial, and in this case would not be present for the patient. And then if you think, just using some quick figures here, if our average collections on a Medicare patient is around $85, the patient responsibility for Medicare patients is going to be typically, I think, in the 10 to 20% range of that. So not a huge amount of out-of-pocket money for the patient.
Michelle,
I have a question. Sorry, go ahead.
no, I was just asking if Michelle had her hand up.
Yeah, Michelle, you had your hand
I
up
do.
still?
Yeah, I do. I had a couple questions that
Yeah,
I was
Roxanne,
just
you're
wanting to
after
ask.
Michelle, so thank you.
So regarding the billing, you said that this was billing at a level 2, level 3, but then you mentioned that it's not going to interfere with the E&M code. So are you billing E&M codes for your telehealth to where there's going to be 2 E&M codes if the patient requires transport? And then my second one in that realm is, you also mentioned the payer payments for Medicare and Medicaid equivalents. I'm wondering what you're billing commercial payers when you implement this into those systems.
Okay, the first one, the answer is, it is a telehealth emergency medicine code, yes. From a payer perspective, that does come across differently from what I understand than an in-person emergency medicine code. For the second question, we're billing whatever we would normally bill that commercial payer for an emergency medicine code.
Can you provide your estimates for level 3s on your commercial payer mix?
I can ask. I truly don't know off the top of my head, but I can certainly ask and provide this to you.
Okay, I'd appreciate that, because as you look to expand the program, you're doing this for a number of reasons. I think it's fantastic, and I love what ET3 is doing. I do have concerns that when we discussed with AMR kind of how we can help them, the only component of the option that they wanted to even look at locally was alternate destination, and they were set with going with an out of area national service for kind of their telehealth options. Whereas, we feel like locally, I kind of wonder, how well do you know the local resources, where to get people care? Do you have access to their records? When you're doing the COVID counseling without testing, do you know where they are going to get tested that day with same day turnaround? Are you able to identify all those risks and who's a candidate for treatment and those things? Because I think that's one thing where enhancing this locally, we can bring a lot of options. And I'm a little concerned at making certain that rather than just counseling about COVID, these people are tested with a good high quality test, because most people have already done antigen testing at home. And if it's negative and they're short of breath and coughing, they want to work through this, right? And you know how many people walk into your ER and then have a positive PCR, and it's like, oh yeah, their BMI is 31. Now they're high risk. They need Paxlovid. Got to look at every drug. We need renal clearance, and figuring out which of those patients will really benefit. Also, a lot of these patients are very complex socially, and I want to ensure that they get the right care, the right wraparound services, the right social services that can be provided by some of the local options, that may be more difficult. And so I'm just wondering what resources you have, what access to their medical records you have, and how thorough you're able to be in that 10 minutes.
Sure. Now, all those are very fair questions. And our vision for this is really over time as volume starts to go. 1 year ago, we were averaging about a call a week. And so it's taken a slow roll to do the education. I'm a part of every bit of the education and everywhere Kelly and Mitchell go to do the rollout. I try and work closely with the local EMS medical directors on that education and then provide feedback. But you're right, there's local flavor to this. And I say that being a local EMS medical director, I'm obviously going to know the alternative destinations and the scene in Plano differently than y'all would, just like you would in your area. So one thing we can do is we can take any documents you give us and we can post those for our physicians to have access to as treatment resources. But really the long-term, I think, good setup for this is to partner with local physicians, and that our national group move from being primary on call in an area to have more of a backup role. Because as we all know, as emergency physicians, there are times where you get 2 patients in an hour and 20 patients in an hour. And it's hard to predict sometimes when those will be. And so developing a tiered system for call will be really important. And I think over time, how this turns is you've got local physicians that take frontline, and then it bumps through to a regional or national multi-state licensed backup so that EMS is never waiting too long. And so I think there could be some good partnership there. And I'm very open-minded about including physicians in that group.
I see Mitchell had a question.
Just to kind of hit on one of the points that was raised earlier and provide some clarification, I think there was a concern about patients wanting transport and not being offered transport. I want to make very clear that this is an opt-in program from the patient side. So at no time are we telling a patient that they cannot or should not go to the hospital. This is presenting the patient with an alternative option and helping the patient understand both the risks and benefits of that and what's going to be the best decision for them in their circumstance.
Also, Roxanne, you have your hand up still. And then Harry, I know you raised your hand physically, so I know you're in line. So Roxanne?
Yeah, so related to that, what does AMA look like for these patients who either get seen by telehealth? And I'm sorry if I missed this in the beginning because I was a little late. I just want to know, like, what does telehealth look like for patients who either are seen by the physician via telehealth and decide not to get transported, or not, for whatever reason, just don't get actually transported to the ER? Will AMR have to change their processes or even their documentation for that?
I can answer that. Mike can probably jump in on that as well, but I'll tell you, no, we don't make any changes to the AMA process locally unless there is a specific request for it. I will say there's some operations that have been live for longer that have expanded their program to utilize, the telehealth physicians, more. But generally with the implementation and certainly what we're doing in, Monterey, the AMA process would be exactly what it is right now, which, I assume is, going through med control. So
okay,
the
great.
telehealth, yeah, it's not going to change that process at all.
Yeah, and this is Mike. I mean, I would agree. I wouldn't expect probably any changes to the AMAs. I think it's just really the option kind of between the AMA and the transport for those, really, really low acuity patients. I think that Mitchell could probably offer some insight on the patient types that we're looking at. But again, I think that you're looking at patients that otherwise would need a prescription refill or something along those lines, rather than just transporting them to the ER.
I would
Can
also tell
everybody
you,
hear me?
sorry.
Mitchell?
Yes.
Did you have something?
Yeah, I would also add to that that something happens with these patients when they're sitting face to face with Dr. Gamber or another member of his team, and they're suggesting that these patients be transported. We have very few patients that are recommended for transport by the physician and AMA after that. Much fewer than I think we encounter as EMTs and paramedics, trying to probably have that same conversation with a patient, but having a physician there, hearing it from a board certified ED physician that this is what I would do for you if you were in my emergency room, and this is why I think you should be transported. We're seeing higher levels of transport after recommendation for those physicians than we do otherwise.
Harry, go ahead.
Yeah, shifting gears just ever so slightly. Looking at it from an operational standpoint, this system requires almost 100% perfect communications between the field and the doctor. Can you comment upon, the reliability of your communication system? And obviously that's dependent to a great extent on the local communication system. Here in Monterey County, we have a very varied topography, which comes replete with a variety of communications challenges from time to time. Could you comment on the reliability of the system from a communication standpoint, and how many times you've actually lost communications with the field and had to resort to transport as a result?
I could, before you jump in, Dr. Gamber, I could tell you a little bit from the operational side, because, that's a really good question, and actually something that we've spent significant amount of time and invested in within the last year, because we did initially try to implement, with Wi-Fi and the ambulance modems, and we did find connectivity issues. And as a result of that, our IT department has done quite a robust outreach to every market that's participating in this. And certainly they'll do that work with Monterey before they go live, where they do a significant amount of field testing on the devices to identify what's the right connectivity solution. Generally, we've not done Monterey's yet because, we don't yet have approval to implement, but generally we're finding cell phone tethering and or SIM cards, or a combination of both within the devices in the field, to be the most effective at connecting to the provider instantly and staying connected every time. Because you're exactly right, there has to be some form of cellular signal, right? And if there's not, for areas, we see this in, Boulder, for example, up in the mountains, in some very rural areas, such as maybe Stanislaus County up in California, where they don't have a cellular signal. But that is also part of the training and testing we do with the crews, to say now our platform as a test, if you don't have connectivity, don't offer telehealth to the patient. So that is kind of part of the crew training, to say, they can easily see now, they have the tools to see if they have connectivity and a strong signal before even initiating the visit. But certainly I'll also let Dr. Gamber jump in, because as he said, he's been with us since the start and has worked through the earlier tech challenges, which, I hope we see very few of nowadays, but we certainly did in the past.
Alex has a question.
More than a question, I wanted to clarify on the connectivity issues here in Santa Cruz. All of our devices do have cellular device, but the e-visit program allows for patients also to use their own devices. And we've seen here that oftentimes patients are able to connect through their own home Wi-Fi. So that bypasses completely the problem that we would have for having no cellular connection. And that actually worked in 2 of our cases recently, for 2 calls here in the Santa Cruz Mountains.
Could I just ask, though, it appears, I think Dr. Gamber is muted by the admin. I don't think he said he's not able to unmute himself.
I haven't unmuted anybody, but I'll take a look to see what I can do.
He's the 972 number.
Okay.
Yeah, you're exactly right. So truthfully, what we've rolled out is, Alex, you brought up an excellent point as well. There's the crew devices that they can use, but the providers also have a process in place for connecting directly to the patient's cell phones if they choose. That's generally the best practice we train on, because generally, again, nothing's a certain, there's no 100% in EMS is there, but generally the patients will have a stronger cellular connection, either because they're on their home Wi-Fi or they're on, the strongest network. So when we train the crews, we give them multiple options. If their devices don't have connectivity, which again, I think should be very rare, they also have the option to, and the docs will ask, do you want to keep this on your device, or would you like to transfer it to the patient's device? And I think that
Kelly,
has
it's
helped
Mark. Can you hear me
significantly.
okay?
Yes.
Okay, good. Sorry, I'm through the mute now. Thanks for unmuting me. So you're exactly right. We start off with a program that does require a little higher bandwidth built in. By the way, the patient has, when they give us an email, they get a link that gives them access to my medical record, which they can share with their primary care doctor or anybody else they see later on. They also have access to work note or school note from that EMR. Sometimes because it has an EMR built into it, it's a little higher density or bandwidth needed, and we can move over to a secondary visit type that is much less bandwidth needy. And usually if a patient and or a crew can get 1 to 2 bars of cell phone coverage, that the version of the program. And if we cannot complete a video visit as part of it, then we don't do the visit. So that is, Medicare criteria that we do not just audio, but also video. And so we ensure we do both.
All right.
So I have a quick question. You mentioned the access to the EMR and having those accesses to the notes and everything, which is fantastic, but we have a fair number of low acuity, non-tech savvy folks that honestly, you can give them almost any link you want and they're not gonna probably be able to access that. So for somebody who needs a note for something or things like that, but doesn't necessarily have that tech access, will the medics be printing it out directly for them? Will they have some other access point for these records?
I do also receive a text link. So, or I'm sorry, a text. There is a link in the text, but there's also a phone number that they can call. In the rare event where, say, a patient doesn't give an email address, or you're exactly right, they don't check their emails. The text that they also get does include a phone number that they can call if they need access to their records or follow-up information, or to get back in contact with the physician, basically anything that they may need as a follow-up to their telehealth visit.
I'm just thinking of some of those folks that say, because if the medics are using their iPad and get a good connection when they're out at the tent or so, and we've got a lot of people that are not well connected tech wise, they're living in cars, frequently have no service, no charge, nothing. Will you be able to provide them with, say, a written prescription as an alternate, or call in the prescription, or written notes or things like that?
We're certainly happy to call in prescriptions. We've run into that a number of times. Normally we send in electronic prescriptions, but happy to call in prescriptions, and I've done it 50 times already. We don't do controlled substances, and so I do want to be transparent about that.
Great. So it sounds like there's a paper process for them to get a written aftercare instruction, written script, kind of work notes and stuff if they don't have access electronically.
So I can tell you the prescription is not an issue. We're very used to calling them in if it won't work electronically. There's probably a way we could engineer the written work notes and things like that, and I'm happy to brainstorm on that with everybody there. Admittedly, I have not done that outside of the EMR. but I'm open to it. It's certainly something I'd love to figure out.
Great. And then have you guys, I mean, I know you get kind of local one-off failures and stuff like that. In terms of the overall telehealth service, I'm assuming if you guys have power outage or on battery backup and things like that, so you're pretty much up and running. You got cellular backup to your Wi-Fi and all of that. So this system is pretty robust. Is that correct?
Yeah, we on the physician responsiveness side, you know, we're all really running off of high-speed home Wi-Fi, but then we can hotspot off our phones, and it's not come to that, but you know, we all have complete cell backup at our phones for hotspot. Me, for example, I can run this off of 2 bars of cell phone coverage off of my laptop hotspotting. I've got 5 bars at my house, as do all the physicians, because we're in pretty urban areas. So we've not had a physician lack of connectivity issue.
Perfect. Thanks.
You bet.
Are there any more questions?
Did we have somebody that was going to go over the data and some of the systems that have done more cases? I know we heard about, perfect. Never mind.
Yes,
I can-
ma'am. Perfect timing.
I can speak to that.
Yep.
So,
Great segue.
quick overview of the Syracuse system. I think that's a good one to use for comparison. As Kelly said, we've been live for going on a year now. We launched in July of last year. Our growth has been intentionally controlled. We wanted to build this program slowly, take a close look at all of the calls we were doing, and make sure that we were growing this smartly and with the best interest and safety of the patients in mind. So you can see where we started out in July, actually no calls, telehealth calls. I think we had 1 or 2 in August of last year. And we've been steadily trending upwards to the point where we're now averaging 1 to 2 telehealth utilizations a day. Our medics are very familiar with the program and comfortable at this point troubleshooting some of those rare technical issues with the patients. You'll note we did have a spike in January of this year. We were a COVID hotspot to the point that we had FEMA resources deployed to the area, and to load balance hospitals, we were routinely transferring inpatients 3, 4, 5 hours away from home to find facilities with room to home them for several days. So in that case, being able to use the telehealth service for a lot of these lower acuity patients took quite the load off of the emergency rooms and provided these patients with more timely care than when we're looking at 8, 10, sometimes 12-hour waits in the waiting room to be seen. And I know Dr. Gamber hit on how his group was able to address some of those lower acuity COVID patients. And these are, in that case, are the, patients without respiratory distress with oxygen saturations, room air oxygen saturations over 94%. And it was a team effort between our EMTs and paramedics and the physicians. We went so far, I know there was a question earlier about local resources, but we went so far as to equip our crews with a handout that they could give to the patients that listed testing locations and hours. So, when the physicians were recommending self-care and monitoring and testing, we could step in and be able to show them when, where, and how they would be able to get a test. Next slide. Another view of the growth of the program, and I think this one articulates the low acuity aim and the safety that we have. We're up to about a 20% screening rate of the patients for low acuity complaints, and these are the patients where our crews are putting them down that algorithm to get that recommendation from the software yes or no, this is a patient that potentially qualifies. About half of those patients are qualified by primary impression and vital signs. And then right now we're looking at just short of 2% of our overall 911 patient interactions meeting the inclusion criteria and consenting to move forward with a virtual visit. So small volumes, but making sure that we're capturing the correct patients. I think one of the keys to this program is keeping it patient-centered and making sure that we're right matching resources to patients and not allowing patients that would not be good candidates for virtual visit or telehealth care down that pathway, but having that discussion between the crew and the patient about what that patient's needs are. There are some patients that call with a valid, substantiated complaint, but don't want to go to the emergency room. They're looking for other care, but maybe don't have access to primary care, or don't have the ability to get to an urgent care. This program is the perfect solution for them. We've encountered patients that need some form of acute or subacute care, but have problems with childcare and aren't able to transport their entire family to the emergency room with them, don't have anybody that can watch the rest of their household. So having the ability to bring the care to the patients in these cases is really, I think, made the difference in them being able to access care versus not access care. Prior to the option to implement telehealth, we really had two options. We transport the patient to the emergency room or the AMA. This allows us to kind of bridge the gap between those two, find those correct subset of patients that can benefit from bringing the care to the patient safely and treat them in their residence. Next slide. And a couple real world examples. These are just brief summaries from some of the many telehealth calls that we've had in the Syracuse area. On the right side, you'll note the more common complaints that we've been able to successfully address through telehealth. And then a few examples of really that I think that highlight the low acuity natures of these calls and the benefit to the patient, whether it's a patient who needs a refill on his albuterol, has no distress, but doesn't have access to a primary care provider. These are patients that are most likely using the emergency room for primary care. Being able to get them that prescription before they need it, it has been a true benefit. I think we've talked in depth at this point about the COVID patients. And then the last example there was a male with leg pain after working out. He did not want to go to the hospital, but was kind of at an impasse for what needed to be done for this. And in some cases, these calls are physician reassurance, assessment, and recommendations for over-the-counter medications, as was in this case. And this patient was extremely happy to be able to remain at home. So any questions about the implementation or the how telehealth looks in Syracuse, I guess, as an example for what could be out there in other areas of the country?
Just one quick question on your list. I saw behavioral or psychiatric crises. Are these patients then being screened by a crisis intervention team, or it's kind of a high risk group in terms of getting them to right resources and ensuring, I don't know, our crisis assessments usually take an hour. So
Yeah,
it seems like it'd be difficult to do in a 10-minute time period.
So these are not patients that are suicidal, homicidal, patients that are depressed. These are primarily patients that have and other psychosocial issues would fall into that category there. So this is where we may bridge the gap a little bit to case management. We may be talking about patients with an acute episode of their chronic anxiety. We certainly are not making the determination about whether or not someone is in acute crisis or needs further recommendation or further treatment. I think the other benefit of having the physicians involved there is, like Dr. Gamber said earlier, if that story migrates from what they tell me on the road to what they tell him as the physician, or if he elicits a different response for that patient, he does have the ability at that point to recommend for transport. And if that patient were to make a statement that include one of the physicians into them requiring further acute treatment for a behavioral health crisis, we would then put them back down the mental health law pathway. So it adds a safety net.
Oh, no, that makes sense. But so you're talking a little bit more about social related issues, but the column says psychiatric and behavioral crises. So, I mean, it's just very difficult to determine whether this is a chronic issue versus an acute psychiatric emergency without getting into a lot of details sometimes. So 5 to 10 minutes on a visit is really short for that assessment. It sounds like these maybe what you're saying have social issues that are kind of combined, or are you sending them to alternate destinations, wraparound services? I guess, how are we ensuring these people are getting the overall care that they need, not just the, okay, you don't have an emergency medical condition to go to the ER. You guys, I think you're stable for this, in such a vulnerable group. Because part of the reason they call 911 is a lot of these folks don't really have the resources or capacity to access and do these things well on their own.
Yes. So we in New York do have the ability to transport these patients to alternate destinations, one of them being a behavioral health center. So if there were any concern, we transport patients. I know that's not the model that we're looking at for Monterey County. And that may be a little bit of bleed over from trying to compare one site to another that's slightly different. So not necessarily an apples to apples comparison, but I think looking at the the much larger number of cold and flu symptoms, atraumatic pain, nausea, vomiting, the general GI upset, just trying to highlight the low acuity nature of these calls. And I believe probably you're correct that there were, because of the way these were coded, there are probably some.
And Mitchell, if I could add in for one thing, it does show that we have a national program, but we look at things locally too. And we'd be very willing to look at and talk about local needs. Syracuse, I happen to be from the same residency as their EMS medical director. And so Dr. Cooney and I have known each other for a long time, and we're trying to work through the national problem, but on a local basis of, is there anything we can do to help with psych triage? Can we triage them to directly to a crisis center? Sometimes the crisis centers require an emergency physician to sign off on the patient. And so, in my ER doctor life, I do a lot of that, as do all the docs on this call. There's a percentage of those patients that say, hey, I need an evaluation today, but they may be okay for a video telehealth conversation and then direct to crisis center transport rather than direct to ED transport. But that may not be right for Monterey County. This is a new area, and so that's what Mitchell and Dr. Cooney and I are talking about. Same thing with Brian Clemente, the EMS physician out of Buffalo. We're spending lots of time talking with local crisis centers and mobile crisis evaluation teams just about operationally, can we do this? Is there another way besides just parking the patient in an overcrowded ED to be waited to be double transferred to a psych facility? I'm not 100% sure we can do this, but I do want to be honest. We're talking about it and trying to figure it out because we think everybody could win, including the patient receiving faster care.
Perfect. Thanks. I
So
appreciate
you
that.
mentioned, yeah,
Oh,
it's
I
important to
appreciate that
dig
answer,
in
but what
locally
it's
with each city.
okay. What I guess what I'm trying to get at is it sounds like in this system and Syracuse that use this, most of these patients were not just telehealth treat and release. They were sent to an intervention center or some kind of follow-up process directly to address their mental health issue.
So these are, Kelly, can you go back 2 slides? So this will show you the number of patients. The blue shaded area are the number of patients we were able to treat and release. The gray area are the patients that were recommended for transport. In most cases, these were recommended for transport to the emergency department. We do have the ability to transport to alternative destinations. Most of those patients go directly to the alternative destination without consult with the telehealth physician. So yes, and I think the divide there shows how cautious we are with these patients in terms of being able to leave them in place. If we're leaving somebody in their residence, they've been evaluated by the crew, they've met the criteria, the crew believes that it's clinically appropriate, and an ED physician has evaluated them and determined that it's clinically appropriate for them to remain at home.
Okay. And so do you by chance know out of that kind of number of psychiatric patients that you were treating on this telehealth mechanism, what percentage of them ended up at either an alternate destination or ED, or really, I guess, their dispositions in terms of how they secured the kind of stabilization care that they needed in the end, where most of them referred like to outpatient psychiatry? Do you have their dispositions? Because it's just a high risk group.
Yes, offhand, I do not. I would have to do a little bit of digging for that. But I can also tell you that in this group of patients are those patients who are anxious, looking for a little bit of reassurance. We're able to work through whatever the acute problem is with this patient. Prior to telehealth and prior to ET3, a lot of these patients would probably end up AMA in that case, but now we're able to present them with a physician to talk to and ensure that they're comfortable, they have what they need. In some cases, it may be requiring medication refill. In other cases, the physicians are able to recommend for follow-up care and treatment.
Okay, thanks.
Also, just to follow up on that as well, again, we tried to put a national protocol in place just to allow all operations to get up and get started, quite quickly. But it is, as Dr. Gamber and Mitchell said, it's very much a local program, and our markets that have been live for quite a while have, expanded, grown, found different use cases to add value, to their patient population. So, on that same vein, if we wanted to ensure that, we didn't ever offer this to anybody whose patient complaints that might be related to behavioral or anxiety or depression, we very easily could also exclude that in Monterey because, this is your program for your community. And we really have that ability to make that flexibility locally if you just want to, if you don't want to offer them telehealth at all.
Harry, you got a question or comment? Harry?
Yeah, a question probably for Kelly. Bilingual capability, that has not been mentioned, and it's very germane for operating in Monterey County.
Yes, sir. Well, that's a perfect question. 2 things, and I don't want to speak for Dr. Gamber, but I understand just for Spanish, the majority of the physicians just already speak Spanish. So that's almost an easy win. But They are rolling out, it's actually the physician group are rolling out the medical translation services, and the company that they're partnering with is used, by hospitals, across the nation right now for clinical translation. I think they support 63 languages. So we will implement that if we are able to implement in Monterey County. So essentially, a patient that speaks any language, we can get them connected to the physician and bring those 24/7 medical translators on immediately to, provide that additional layer of care for the patients. And on a personal note, it's something I'm very excited about because I think it's, it's a gap we see across the nation. Short answer, yes.
Okay.
Yeah.
All right, I don't see any more hands or questions, so if you guys want to move forward.
Yes, fabulous. We'll hand over to Ben and he can speak in depth to the QA process that will be in effect in Monterey for ET3 patients.
Morning, everybody. So we created a fairly simple QA/QI process that we're hoping to expand over time. One thing, or a couple of the things we're committing to, it's a 4-step process right now. We were hoping to audit 100% of all the ET3 related PCRs, and some of the criteria we've listed on the screen. Was the patient over triaged? Were they under triaged? Asking that, was this condition appropriate? Did it fit with the inclusion data into the inclusion guidelines for ET3? Did the use of the telehealth system actually cause any significant delays in patient care? That kind of ties into where they over triaged or under triaged. If you have a condition that wasn't necessarily appropriate for inclusion into ET3, was that attempt to fold them in, did that result in any significant patient care delays? And then the review of the assessment and the adherence to local EMS policy and protocol. Was there something in our local policy and protocol that should have dictated immediate transport as opposed to an attempt to enter the telehealth system? We are also committing to making telephone contact with 100% of all ET3 patients and kind of getting the patient's perspective on the program. Did they feel that it was right for the situation? Did they feel that how they were treated was appropriate? And would they use the system again if they were in a similar situation? The attempt is going to be made with 100% of all the patients. Obviously, some people don't like to participate in telephone surveys, but we'll definitely do our best to try to get everyone on board for that. Next slide, please. Using a combination of the Microsoft Forms platform, we have a system that is actually already in place that we use in other aspects of our operation, where we can send an email survey to the patient as well. It's browser independent, can be used on either a standard computer or a mobile platform, basically across any type of TCP/IP connection. Any data gathered is stored securely on the Microsoft SharePoint account servers, and with the permission from the LEMSA, results can automatically be distributed to them as well, simultaneously. So they would get a copy of the email result, and so would we. Keep it. Definitely guarantees that the data is sterile. Everyone has the same information at the same time. And this survey would definitely be emailed to 100% of all of the ET3 cases. Again, this is dependent on the patient being willing to fill out an online survey, but we're definitely going to make the attempt. And then another recommendation we're planning on making is that ET3 receive its own section in the contract compliance group reports, looking at the number of calls, the percentage of total system volume, what the time on task was for each call, which I think is pretty important. If it's to track whether or not it's creating significant scene delays. And then reports on what kind of feedback we were able to receive. Did the patient respond to the telephone feedback? Did they respond to the email survey? And then what those results were. I think this is probably a very good and thorough starting point for our QA/QI process. And then I would definitely hope that we can engage the rest of the local shareholders to see if there's anything that they wanted to add to the process. I firmly believe with any QA/QI process, there's always room for improvement. And so if this goes through, hopefully we can get the group engaged. Is there any questions about what we've presented in the QA/QI part so far?
Yeah, real quick, does the EMS agency have a plan to review these cases? Because I mean, it seems like this should be reviewed by an outside board certified physician that, you know, maybe the EMS agency would be the place for that.
I agree.
Well,
Oh, I'm sorry. Go ahead, Teresa.
oh, thank you. Well, I think that there's an advantage that the program tends to start slow, as we have seen from the experience from other systems. And so it will give us an opportunity to be able to review the cases. As you know, we have monthly meetings with AMR. There's also the contract compliance group. And through some of our other committees, the CQI tag, they do some review of cases. So there's definitely plenty of opportunity for us to do case reviews, not just internally within the agency. And, you know, with Dr. Burley as our medical director, definitely we do bring cases for review to him, and we can as part of the ET3 program. But I think that we have the structure necessary to be able to ensure that the cases get reviewed, not just by AMR, not just by the EMS agency, but even members of our stakeholders with a committee like CQI tag. And I apologize, I was trying to comment earlier, but I was having all kinds of technical difficulties and I was muted for a good part of the meeting.
So Teresa, I really appreciate what you're saying with that. I would look at this program in terms of the EMS agency as more of a pilot within our county. There's a lot of national components to this program that are significant. And to me, it would seem that as a pilot, I agree with Dr. Greenson that we would want to ensure that EMS had 100% review of all cases.
Yes. And Michelle, in addition to that, I think the Teresa touched on this with the contract compliance working group would have devote a section to analyzing the statistics with regard to that in terms of response.
Yeah, and just to make sure, it is a pilot program.
Yes.
It is a pilot program for even at the federal level, ET3 for Medicare. It is a pilot program. So we want to implement it in Monterey County as a pilot program, participate in that pilot program. I think that yes, I think that we have the advantage that because it starts small, that we can pay very close attention and monitor it very, very closely. And it allows us the opportunity to be able to, if changes are needed, to be able to make the changes, in a timely manner. So yes, Dr. Kulinski, it's a pilot program. We will keep our eye on it very closely. I was simply mentioning the different opportunities that there are already within the structure of our committees to be able to review the cases.
I appreciate that. I think, though, I do agree with Dr. Greenson that having 100% review by your medical director would be an important component as you move forward. And while I 100% understand that this is a pilot program now through ET3 CMS, it's clear that Envision has a lot invested in this in terms of trying to find growth and innovative ways to expand this outside of traditional Medicare, Medicaid, to where the impact on the system, eventually could become significant as they find ways, if they're going to do psychiatric clearance and direct treatment to crisis centers and things like that. think these are high-risk groups, and it's just incredibly important as this grows that locally we look at this, that we ensure that patients are given appropriate resources, that, you know, we have that local control to ensure that they get the care that they need outside of that 10-minute telehealth visit. Wraparound services become critical.
Right. Let me
Yeah.
let me just real quick. I mean, so the contract compliance work group cannot do case reviews of every, as a physician representative to that committee, cannot do case reviews of every, you know, ET3 telehealth visit in the county. So I think the EMS agency is going to have to take that on, because I think every one of these cases is going to need to be reviewed by an outside, you know, non-GMR affiliated board certified physician, at least for the pilot program for starters.
Doctor, I totally agree with you. I was looking from the contract compliance aspects of it, just statistical aspects. But
Right, no, I completely agree.
I totally agree with you with the medical
Right.
aspect of it.
Yeah, I completely agree. And I'm more than happy to look at any cases there are problems with or concerns about or anything like that, but that cannot be used as a, you know, there's just no, we just don't have the resources, and, you know, and that is really not the committee's job to run the, you know, quality control or review process for GMR.
No.
And this is Mike. You know, just to kind of reiterate what we've talked about, you know, while it is a, you know, a pilot program, we certainly have the ability to, you know, do some tailoring locally. So if there's even certain, you know, complaint types or things that we decide that we, you know, need to exclude, I think that that's an option. And our intent as well is to kind of leverage, I think, the best practices around the nation with these other areas that have implemented, but also look at, you know, local elements as well. So I think that that's something that we'll continue to strive forward, and we can, you know, always, you know, even as like we do in TQIC and those types of committees, find ways that we can do case reviews and figure out, you know, what are the strengths and weaknesses of the program and what we can do to improve.
We may even consider the creation of a separate working group that would probably be a little more effective versus passing it on to a different, to one of the other subcommittees or working groups.
So I
and we
think
can
one of the
definitely talk about that. You know, again, the program, from what we've seen, it starts pretty small. We saw that with the data from Syracuse. We saw that with Santa Cruz County. And we've seen that. I actually got to see some presentations when I went to the ESO conference, and the programs tend to start very, very small. So yeah, so it gives the opportunity to do 100% review of cases. And for growth, we can control that as well. You know, how and when it starts to grow, then that's something that we can decide. We're having this conversation here to make sure that if moving it forward is the right thing for the system. We wanted to make sure that all of your questions were answered, and as it grows, and we will continue to have the same conversations to make sure we want to do this in order for us to increase the chances for something to be successful. We kind of have to, I like to take very conservative approach. And I think this one is conservative. We didn't, you know, time also the timeline for implementation, looking at, for instance, at alternate destination. That would have taken us a lot longer to look at. But we want to be safe in any program that we implement as a pilot, or any changes that we make to the system, and monitor to make sure that we minimize risk and increase chances for success.
So Teresa, do you have an EMS QI program kind of that you had envisioned to audit and QI all the ET3 cases, or how you envision doing this as separate from AMR GMR program? Because I think the point that Dr. Greenson was making is that they need to have oversight as they implement this pilot.
Did you repeat the last part of your question?
I asked if the EMS agency has drafted a QI program that they plan to implement to monitor the ET3 program that is separate and independent of AMR GMR's QI program.
We have not drafted a written plan, but it you know, it is our plan to review the cases, and I think that perhaps
Dr. Burley and Deborah, who are more on that clinical side, they can speak better to that, to your question.
Thanks, Teresa. So yeah, I agree with the sentiment that's been expressed by the group. I think it's important in any pilot program that the EMS agency is overseeing the program and making sure that there's no issues with quality, and that any issues that do come up with quality are addressed quickly and in a timely fashion. So I think it is important that we are performing QI independently of AMR, and that's the intention of myself as medical director in this pilot program, to be engaged in that process and be reviewing these cases on a regular basis. As Teresa mentioned, we haven't developed a written plan for that yet, but that's certainly the intention moving forward. Now, understandably, these cases are coming in at a small number of cases per day currently in other systems, and we would anticipate the same thing in Monterey County. But the cases may grow, and it may get to the point where it's not reasonable for me to review every single case as it goes through. But at that point, we've probably had 6 to 12 months of experience with the program, and we can feel more comfortable with how things are being done. And even then, I think that it's important for us to continue to do QI review moving forward. So that's sort of the general philosophy of what we're looking at here. I'm happy to answer any questions.
All right, anybody else? All right, Steve, what do you need from us now? So.
Good question. So if discussion is over at this point, AMR has asked for endorsement of our 2 committees to move forward with this project. And so we would need a...
So Steve, I'm sorry, before we move on, has the EMS agency received Salinas Valley Memorial's letter of concern yet regarding this program?
I've not received it.
Okay, can you give me like 30 seconds just to talk real quick about some of our concerns?
Go ahead, Nicholas.
Yeah, so I don't know what we want from our EMS system and what our community wants that we're representing and trying to do the best service for. But we have some concerns about the corporatization, particularly for the fee-for-service corporations that seem to be taking over the Monterey County EMS system. So particularly AMR, which obviously has the exclusive ambulance contract in Monterey County, obviously is a fee-for-service, profit, publicly traded corporation that's owned by GMR. And then CalStar, once again, is also owned. This parent corporation is owned by GMR. So both the ground and the air components of our EMS system are run by essentially the same large company, for-profit company, which I think is okay, but it creates some major conflicts of interest. And so our hospital per se does not have a problem with an ET3 program, but we're really concerned about the further corporatization of our EMS system, because I think this is the first step of turning over physician medical control of the system to this outside entity, this this for-profit driven entity, and they're all owned by the same corporation. So I think there are huge conflict of interest, and we have some really large concerns, about just turning our EMS system into essentially an extension of the GMR corporation, a for-profit, company that's publicly traded. And I don't know what comes after this, the air, ground, physician medical control. GMR is a really big company. They own rural metro, so they can do fire services, they can do EMS dispatch. And I think we would be really careful about how far we want to go in terms of privatizing our entire EMS system, especially since we're turning the control of it over to a for-profit private entity that's owned by the same corporation and has huge conflicts of interest. So anyway, that's just one of our concerns that I wanted for the committee members to just keep in the back of their head that, we're turning over another component of our public EMS system to a for-profit corporation that's owned by the same parent corporations for CalSTAR and AMR. And I think it creates a huge bunch of conflict of interest. And I think doing this some different way from a local level would avoid all those, and we could actually provide, better medical care to the patients too. So anyway, so I just wanted to bring that up.
Any other discussion?
I will say that we have had some similar discussions through CHOMP and Montage, and primary concerns about ensuring that how should we say, that appropriate resources that frequently aren't traditionally given through national telehealth platforms. And I have no direct relationship or kind of experience with Envision specifically, but there's a ton of national programs out there. They don't provide the patients with all of the resources that they need. I do have concerns with exactly the things that Dr. Greenson is reflecting. I do have concerns that Envision has been unable to provide us with their commercial charges, which is interesting because if they're looking to expand and they're open to all payers, as most people know, commercial payer shift is how people make money. And I think that it's very much altruistic, but it's clear to me that this is a program that is being started with a goal to expand. It's been done in a very good way, but again, not necessarily locally focused. And I think we may be able to provide some resources locally that might not be available in this system.
Thank you. Any other comments? With that, Steve, what's the next steps?
The next step, it would be that, again, because AMR has asked for an endorsement of this program, we would need a motion that's actionable to basically say that this group believes that we can move forward with proceeding with the ET3 in the limited capacity in which it's been proposed. Again, there's potential for a great deal of expansion, but that's not what's on the table at this point. It's taking care of very low acuity patients, providing a telehealth benefit to patients on Medicare, and also some Medicaid, Medi-Cal expansion, which has been approved, and working through under EMS medical direction leadership to create this program as a benefit to the patient, to help with manage cost, to keep them out of the ED, to manage crowding in the ED potentially. Those are the things that we'd be looking for, but basically looking for a motion to move forward with that with this project.
And then Steve, real quick, again, this is a pilot program that the EMCC or the medical groups can at any point say, this is not working for our county. And if we don't jump on it, it's going to be another, I guess, 6 years, because it's a 5-year pilot, correct?
That is correct. This is a pilot Medicare or CMS program, and this is our opportunity to do it. And we can, as a system, decide if it's not working for us to make a change in the future.
All right. Is
So,
there a motion, anybody?
Can I ask one question before we motion to what Steve had just said? Is the only option under ET3 to use Envision telehealth? Or are there alternate things that could be implemented locally that could still gain ET3?
I'll let one of those who know the program better than I would believe that we could, but let them speak to it.
Yeah, I think that we'd probably have to do a deeper dive. It's hard to say. I'm sorry off the top of my head, just because we have not done anything like that in anywhere else nationally. But I guess I certainly, I'd have to give it some more thought, to be honest, on what kind of what that might look like.
I will give you. I've actually done quite a lot of looking at ET3 documentation, even going into the Medicare information, from CMS, and there's no limits on who can do the telehealth. This is mostly on, on the front end. Who does the physician part of it is not specified. It doesn't have to be Envision. However, they are the group that's ready to go. And if we're going to make this work, we need to be ready to go.
I should mention that that was the model that we created when we applied for the application and got the program approved through CMS.
Yeah, well, real quick, why weren't we, why didn't you guys partnership with anyone locally to try to set something like this up? I mean, why wasn't there an interest in doing that? Because it just would seem to make from a medical care so much more sense.
Yeah, I mean, within our company, I can let Kelly or Dr. Gamber, chime in. But I mean, within our company, it was a national program that we pursued. So that was basically the reasoning. But it's again, it's a pilot program, certainly in the early steps. And I do think that those are things we could probably explore in the future.
Yeah, and again, just off the cuff at a very high level, just because again, I apologize, I'm a bit on the spot with not having thought through this previously, but I think that was exactly it, that we, the goal of the national program was to make something, that was plug and play, that we could apply, do a lot of the work to alleviate a lot of the burden off every individual operation from having to stand up, their own program. We have a lot of consistencies, that we can leverage, again, say even just the size, the response times, the data, the monitoring, none of which, of course, is prohibitive. As you can imagine, leveraging economies of scale really saves every individual operation from trying to stand up their own program. And at least a few of the operations, that I have spoken to, certainly not everybody would have had the ability to stand up their own telehealth ER physician group with the EMS background, answering in 5 minutes. And we just do, again, there's so much follow-up and case reviews. And I think having those consistent groups of technology issues, for example, that we saw over the past year, having a lot of the things I talk about in training is having the, consistent providers, just quite frankly, has been a huge benefit because they're so, familiar with what's happening in other areas, and we can leverage those economies of scale. And that's just off the top of my head. None of it is prohibitive at all, but it just seemed to make the most sense for everybody, for, the operation specifically, to make this as easy as possible on them.
I think I would just reiterate that point is that, it's not that we're closed to the idea of having this program be carried out on a more local level by local ED physicians who are board certified in emergency medicine, but trying to find a group of ED physicians who will commit to being available 24/7 to answer the phone and to get on the line with patients within a few minutes and provide this coverage at the reimbursement rates that we've kind of gone over here, I think is going to be extremely challenging. And maybe you can find a group that's ready to roll and ready to do it more on an altruistic level. But I think there's going to be real challenges to that. And so again, this is not sort of like we make a decision and then we lock the door and walk away. This is a program in which we say, look, maybe this isn't perfect. Maybe this isn't exactly what we want, but this is a step in the right direction. And we still maintain control to change it and adjust it and maybe alter it in the future if we have the pieces in play and the interest and the commitment from the community ED physicians to do that. So I think this is a good step in the right direction, but I also want to encourage Dr. Greenson, Dr. Kalinsky, you brought up, concerns about this not being done on a local level. And I think those are legitimate concerns. And so, I would suggest putting a group together to look at whether this is something that could be feasibly done on a local level. But in the meantime, I think it's a good opportunity for us to kind of get the ball rolling and see how the program goes and then decide whether we have the bandwidth to do that locally.
Dr. Burley, are you making the motion?
Sure. I'm not a committee member
You can
of,
make the
Oh,
motion.
wrong
Yeah.
committee. Okay. Which committee has to make the motion, Steve? Is it the
We would need
EMCC?
a EMCC member to make the motion and an EMCC member to second. And then my recommendation would be for a MAC member, when it comes time for MAC to do this, to basically reference the same motion so we don't have to reconcile in the future. But the discussion on the motion can be with both committees, so we should be able to get the motion correct at the start. Again, EMS agency staff is recommending that both committees endorse the movement of ET3, move it forward as described for Medicare and Medi-Cal or Medi-Cal patients for the low acuity as described, subject to quality improvement review.
All
That's
right, can I
what we
get a
recommend.
motion to what Steve said? Harry's motioning. Can I get a
I will
second?
make that motion, providing that everyone involved understands this is a pilot program and it does not have degree of local involvement that we might find optimal in the future.
Thank you, Harry, for that. Can I get a second?
I'll second.
Jim Langbird is seconding. Steve, can I get a roll call?
Yes, we can. Will Hiller,
Aye.
Tina Nieto,
Aye.
Sam Klemick. I think Sam may have dropped off. Jim Lamborg,
Aye.
Harry Robbins,
Aye.
Jody Schaefer,
Aye.
Luz Garcia. Now here, Paul Wood, he's still with us? Nope. Nicholas Greenson,
No.
Greta Steinbrunner, not here. Carlos Spencer, John Anthony. Let me move over. All right. Roger Reinhardt. Let's see, we had Sam vote, so Cheryl Getz, let's see, we don't need that. Ben Harvey, are you on? Joe Cafaro, did you make it back? Bandy Smith. All right, so we have we have a majority for voting for with one no.
Hey, Steve, it's Michelle. Is AMR, is it not a conflict to be voting on something like this?
Yeah, right.
Good question.
I mean, right, it's a huge conflict. I mean, no one should be voting from the same corporate entities on a community oversight board. I mean, this is just nuts, to be quite frankly honest.
Then I would recommend Will Hiller to change vote to abstain.
We would be supportive of that. Yeah, this is Will Hiller. I'll go ahead and change that vote to abstain then.
Okay, then that means the motion still passes, one nay and one abstaining. So
Right.
Steve, what's next?
Mac would need to vote. Again, any AMR reps should probably abstain.
Dr. Burley, I'll turn it over to you.
Are there any CalSTAR representatives for either one of these meetings?
There technically would be for Mac, but he's not present today.
He's a voting member on the MAC?
Yes.
Correct.
okay, thanks, Tina. So we'll go ahead and entertain a motion for the same motion that was on the table for EMCC. Steve, we need a primary and a secondary motion for Mac.
This is Tina Nieto. I move with the same thing that Harry stated, that we also look at if we could do it locally. And so we can keep it more into the community for local input, recognizing it is a pilot program. And so we're not locked into this forever.
Okay, thanks, Tina. Do we have a second on that motion?
Second.
Thanks, Dr. Orchard. So we have a motion and a second. We'll go ahead and take a roll call vote.
Sure. Dr. Kalinsky,
Sorry, nay.
Dr. Hawthorne, I think he may have logged off. Do not see him on. Dr. Orchard,
Aye.
Dr. Greenson,
No.
Christy Soboleski,
Nay.
Tiffany Wallace. Don't think she's with us either. Cassie Caldera,
I'm going to abstain.
Carrie Campman,
No.
Will Nealand, I don't believe is with us. No. I think let's see, Ryan Alexander for Scott Houchin. I think he has left as well. Ben Hitchcock,
Abstain.
Jeff Horner is not with us, and Tina Nieto.
Aye.
So we have a total of 2 yeses, 4 nos, 2 abstentions, and several people that are absent. So it does not pass tonight.
Okay, thank you, Deborah. So the motion does not pass. I will turn it back over to Tina.
Steve, what's next?
Honestly, what's next is, the EMS agency will take under advisement the endorsement and lack of endorsement by the 2 committees, and we'll proceed as needed to manage the EMS system.
All right, thanks, Steve. Moving on then, our next meeting is scheduled for Wednesday, July 13th. Steve, do we also have to have a meeting for the 30 days, an AB 361 meeting?
Yes, we will need to have a special meeting if we wish to continue under the AB 361 rules. EMS agency is recommending a meeting on July 6th, which would be just a AB 361 determination of conditions, and then we can continue to meet at the regular meeting.
All right, thank you. With that, we're adjourning, and I thank everyone for such a lively discussion regarding the last thing we just discussed. So thanks, everyone. Have a great weekend.
Great.
Thank you.
Right on.